Okay, welcome to this most recent episode of the Akkad and Coker Report. Today we have the pleasure and honor of having Dr. Sunil Rao on. Dr. Rao is an interventional cardiologist and researcher who's been at Duke University for more than 10 years now. He also works in the VA in Durham, in North Carolina. He's a leader in the cardiology community in general, but also in the social media community. On Twitter, he's got 16,000 followers, and throughout it all, having a busy clinical schedule, being very active on social media, and being a leader in the cardiology community. He's also editor-in-chief of Circulation Interventions, and it's kind of in that capacity that we invited him on today. There's been a lot of news recently about a study, now a number of studies that have been retracted in two of the major medical journals, Lancet and the New England Journal of Medicine. And so we thought it would be interesting to have Sunil's perspective on some of that. Just to give some of the folks who don't know the background, there was a study that came out in the Lancet, May the 22nd, talking about hydroxychloroquine and its use in COVID-19 patients. And it suggested, that patients that were treated with hydroxychloroquine in hospitals had a higher mortality. And there was a number of different places, certainly in the media, a number of different physicians who kind of seized on that and kind of trumpeted those results. And then it's kind of slowly, it was amazing to watch, it's June 10th, just from May 22nd to June 10th, a lot of different things unraveled, and it turned out that the database that the company that was behind this study, the company called Surgisphere, that company's data is unable to be verified. It seemed there were a number of different things that were implausible in terms of how homogeneous the populations were across these massive number of hospitals across different continents. There were a number of different threads on Twitter of different other discrepancies. For instance, Mike Johansson on Twitter, a physician in Ohio, did a thread on the implausible confidence intervals given how COVID is so different in terms of mortality based on age. So, as folks dug in more and more into how it is this, relatively unheard of company called Surgisphere had amassed this massive number of data points from a number of different countries and kind of synthesized it together so quickly, it turned out that the company and some of the authors were unable to answer the questions and unable to verify that there was a database, that this wasn't actually some fabrication. And very quickly, then just last week, both Lancet and the New England Journal of Medicine retracted two articles that were based on the Surgisphere data set. And now there's a massive audit ongoing of all the data that comes from Surgisphere. So Sunil, I'm sure you saw all of this unfolding as well. What were some of your thoughts early on?
Yeah, thanks, Anish. That was a great summary too. And I think, my initial thoughts were, of course, your heart sinks as an editor, because the first thing you think of when you have that responsibility is, oh my goodness, is it possible that this could have happened to us? People submitting data that just simply cannot be verified. But then, the sort of more scientific part of me, or the researcher part of me, did find the whole episode somewhat curious. I mean, it's a lot of work to put on something that like that certainly in some quarters people are calling a fraud, and you sort of wonder what is the motivation here to do something like this, and why would someone do that, and to what lengths have they gone to try and create this set of data that ultimately gets published in the two highest impact factor journals in all of medicine. And I've been, it's been really interesting to watch the unfolding of this, particularly because it seems like the investigation into this person's background, this person who started the company, is all playing out very publicly and in the Twitter sphere. And so every day it seems like someone is coming up with something new that they've delved into the author's past that raises questions. So for me, it's really been a combination of wonderment and quite frankly, just sort of fear, because this is one of the things that keeps you up at night as an editor.
Yeah. Is it the place of peer review to catch fraud?
So that is a great question. And I think that that's what we've been wrestling with. I think all of us who review for papers, for journals, and I do, geez, I can't even, probably over a dozen reviews per week if I count the papers that come into circulation. I think it's probably is partly the purview of peer reviewers to at least question the veracity of the data. We've certainly had papers that have been submitted to us where we get peer reviews back, and the peer reviewers ask, we need to, if, let's say it's an artificial intelligence applied to, angiograms, and people say, well, I want to see this code. Like, if this is proprietary, we need to see the code because we need to understand whether the data that are being reported are valid or not. And luckily in our instance, we don't get a lot of artificial intelligence papers, but in this one particular instance, I remember the authors were very forthcoming, and they said, here's our Jupyter notebook. Here's the way that we, programmed this, and it's available for download. It's open source. So I do think that the peer reviewers bear some responsibility, but at the end of the day, the buck stops with the editor. And if there's something that's put out that cannot be verified, then unfortunately or fortunately, the privilege and the responsibility of that position is that you are responsible for that.
Wow.
To what extent, on that note, Sunil, to what extent do the editors question the reviewers, or how much back and forth is there between reviewers and editors?
Yeah, so that's a good question too. I think that it depends. Most of the time, the peer reviewers who do a good job, you don't really necessarily have to question them. And again, we're a subspecialty journal. We get papers that I think impact a relatively small subset of overall medicine. And so the community is small. You can very quickly figure out who's a good reviewer and who's not. And it's interesting, there seems to be no relationship between the prominence of someone in the field and how good a peer reviewer they are. Mm-hmm. We get very, very famous people who give us really crappy reviews. And on the other hand, we get, junior people who give us terrific reviews. In my 16 years after training as an academic interventional cardiologist, or I shouldn't use that term, it's more university-based interventional cardiologist, I should say. I have never been contacted by an editor about my peer review. Having said that, as an editor, I feel very free to contact a peer reviewer and ask them to either reevaluate. And quite frankly, we have told peer reviewers that we reserve the right to edit their reviews if they have said something that can be interpreted as being belligerent or argumentative or, quite frankly, insulting. Now, we don't take out things that are actual content that are important for the peer review. But if there are certain comments that can be interpreted by the authors as being, quite frankly, insulting, we do remove those before we send them to the authors. So it's a complicated answer. I think that editors should feel free to communicate with peer reviewers. And on the other hand, editors should feel very free to communicate with authors who submit. That should be a two-way street.
Right. And also to clarify, is it the case that mostly the authors are not anonymized for the reviewers, or what's the deal with that?
Yeah, so that's a source of a lot of discussion in the publishing world about so-called single blind reviews. So the authors don't know who's reviewing them, but the peer reviewers know who the authors are. And there have been experiments done where there are double blind reviews, for example. And it turns out that when there was a really interesting experiment that was done where I think it was JAMA who did this, I'll have to look it up, but they took paper and they purposefully put in a few errors in it, 8 substantive methodological errors, and did a double-blind review. And they found that, only 10% of the peer reviewers were actually able to pick up on these methodological flaws. So the blinding does not seem to necessarily improve the quality of the review. Having said that, there probably is an influence of where the authors come from. It may be a little bit more in different sciences than it is in the interventional world, where I think, or in the cardiology world, where I think we are by nature skeptical. But potentially in other life sciences and even potentially in other medical fields, where the author is or who the author is may be quite influential. My sense is that it's really not in the publishing sphere where it's influential. It's probably in the grant application arena, where your institution and who you are probably matters more.
Mm-hmm. Mm-hmm.
So anyway, is this the type of thing that you would have caught as a editor? Meaning, I guess this was a pretty high-profile paper. I mean, I'm sure the editor of this particular paper, the hydroxychloroquine paper that was in the Lancet, given how much press there was about this issue, I'm sure that they knew this was going to get a lot of scrutiny. Is this something that you as an editor would have caught because you're a cardiologist? I'm getting to the fact that, when this paper came out May 22nd, and there's a bunch of hot takes from all kinds of people about this. There was a former CMS head that said, "Oh my God, this is killing people," and there was a political flavor to the tweet because, of course,
Sure.
Donald Trump has been very pro HCQ for whatever reason for a while. I remember when I saw it came out that this was supposedly increased mortality 30% in hospitalized patients that were monitored. My first reaction, which I tweeted, which I should really not do. I run into trouble when I do that. It was that this is BS. Because this is a drug that's been out for a very long time. We've used it not infrequently, and we see it on inpatients all the time. These are patients that are monitored. How the heck do you, in a monitored patient, get 30% higher mortality? So, without getting into the weeds of it, like a bunch of other people got into with the study, and to kind of prove that this wasn't right, it just smelled funny that this would, a drug started on an inpatient, and the cause of death being what we think it is, which is arrhythmogenic, would result in this type of signal. Is that something you would have picked up because you're a cardiologist, or?
Well, let me first say that I hope you don't stop tweeting those kinds of things, because I think that's really important. I think I think the effect size is the effect size, and that always raises questions in an observational study. I think where I hope, my sense is that my spider sense would have tingled is when I saw that these folks had all this huge database. Now, if you tend to be a splitter, you can dichotomize clinical research and cardiology into clinical trials work and what we used to call outcomes research or observational research. Observational research, which is what most research is, and what a lot of what I do is all about ownership, for lack of a better phrase, ownership of data. We all want the next big data set. And, when I read this paper and I said Surgisphere and all this, I was like, I can't believe I've never heard of this. Like, why am I not writing papers from this thing? And I went to the Surgisphere website, which was complete nonsense. There's nothing on it. And I said, geez, how are they getting all this data? Like, we need to get these data so we can start writing some papers and some grants. And so I think that was the first red flag I had. It was the fact that, this is a company that no one has ever heard of. And I do work in big data. A lot of people in cardiology do work in big data, and no one had ever heard of this. And for, a company like that to accumulate that much data under the radar is just so unusual. And I think that's probably what would have tripped a warning flag for me as an editor.
Right, which is, given the fact that they were not anonymous, presumably the Lancet doesn't anonymize the authors to the reviewers. That seems very strange to comprehend.
Yeah.
How it passed the test, the reviewers and the editors test. Because again, research is generally, even in the Lancet that deals with a very, very broad range of topics, they will typically send specific papers to people who are in the field, right? Research is collegial. People know, the reviewers will know the authors typically of studies.
But it does seem like this touches on the point that you made earlier, Michelle, in terms of trust and faith, and there's a lot of trust and faith in this job where you take people on what they're saying. And in this particular case, you get a few people that I guess aren't that well known, Tapan Desai and Dr. Amit Patel. And then you had Dr. Mandeep Mehra, who is by all accounts a very upstanding, has had a tremendous career as a heart failure transplant researcher who's at the Brigham, right? One of the Harvard
Yeah.
Boston schools. Would that have allayed your fears? Meaning, would you have seen that and said, or would you have reached out to him? Just how does one suss these things out? Like when you do see something and your spider sense tingles, how do you go about
Yeah. So first of all, let me say, we don't know what the peer review comments were. It's possible, we just don't know, that the peer reviewers actually said to the associate editor, whoever assigned that paper to them, hey, listen, you need to find out what this database is, and maybe that was ignored or glossed over or somehow justified. So we just don't know. It's possible the peer reviewers would have caught it. We have done that. So when I took over as the editor for Circ, I took a cue from Joe Hill, who's the editor-in-chief for Circulation, and Brahmaji, who's the editor for Circ Outcomes, and wanted to create an open line of communication between the people who submit papers and us, who are the so-called judge and jury. We didn't want it to seem that way. So yeah, I would have absolutely, especially if the first author was someone very prominent, I think we would have felt very comfortable and probably compelled to reach out to them to say, we've never heard of this database. Can you please point us to other papers that have been published using it? And can you even provide us with your analytic data set? So New England Journal, oftentimes for clinical trials, will ask for a copy of the analytic data set, and sometimes will even have their own statistician run the analyses to make sure that the statistics or the results are replicable. Now, they didn't do that obviously in this case, and my sense is this I think is emblematic of one of the issues in cardiology publishing specifically, which is that it has become a little bit of a celebrity-driven field, and there's a showbiz aspect to publishing. We call them late-breaking clinical trials, right? It's about simultaneous publications, about making a big splash. And oftentimes, I can tell you from personal experience, it is a little bit easier to get your trial published if it's being simultaneously presented. Whereas if you present it, and then you write the paper and submit it, people have had time to think about it. The peer review is not due in 48 hours. It's often due in 2 weeks. So peer reviewers have a little bit more time to really suss out the things that they want to see. And so I think that this whole idea around simultaneous publication has hurt the scientific rigor of the publishing community, quite frankly, in some ways. And I think this is not late breaking kind of thing, but the pandemic, I think, has created this fervor or this fever to try and get publications related to COVID-19 into press as quickly as possible. And my guess is that, again, I'm speculating here, my guess is that probably the entire review and editorial process was a little bit shortchanged.
Do you think, what do you think the role of the editor is in terms of trying to select what is and is not published? You have the editor of JAMA, for instance. Michelle, to give some context, Michelle wrote this really, really funny piece a while ago. I think it's one of his best pieces, where he talks about different journals and the different personalities that they have. And this was like, you wrote this 2 years ago or something. And now it's like so obvious. It's like it feels like you understand what JAMA's editorial bias is. You understand what Lancet's editorial bias is. And so clearly these are editors that are interested in a certain narrative. So is that, how does that, what do you think the role of the editor is? I'm not saying that's wrong. I'm curious to see what you think.
Absolutely.
What are your thoughts?
Yeah, and quite frankly, as someone who writes papers, I mean, that obviously factors into the calculus when we think about where to submit it. You look at a paper, you get all the co-author comments, you get a final draft, you look at it and say, this is a good Jack paper, and or the fellow will say, hey, we should send this to New England Journal. And you say, there's no way this is getting into New England Journal. Forget it, So yeah, every journal probably does have its own personality. Maybe it's a little less in the subspecialty fields where sort of I live. So the role of the editor, I think, varies. I mean, if you look at the history of peer review, it's actually quite fascinating. I mean, the first external peer review occurred, in the 1730s in the United Kingdom. But contemporary, what we think of as modern external peer review, really didn't come about until after World War II. And Lancet didn't have external peer review until the 1970s. I mean, that's during our lifetime, if you think about it, right? So before that, it was the editor that decided what got in and what didn't. Now, I can tell you about our process. So, and I think this is consistent. I've been an associate editor for the American Heart Journal, and then I was an associate editor for JACC before I became the editor-in-chief for Circulation. And while they have different publishers, the process is similar. So the paper gets submitted, the staff makes sure that it meets formatting, and all of the boxes are checked. And then it gets sent into the editor-in-chief's sort of inbox. We look at it, and the first decision we make is this going to even have a prayer through peer review? And oftentimes at the extremes, it's very easy, right? So if it's a paper that, for us, we don't take a lot of opinion pieces. That's just not what we do. So if someone writes a perspective piece, we tell them right away. It sounds harsh. It's called a reject without review. It sounds harsh, but our goal is really to say, I want to save you some time. So let's just get this to some other journal. But if I'm not sure, or I think it's important, I will then assign it to an associate editor who then will get peer reviewers. The peer reviewers will submit their peer reviews. The associate editor will look at them and decide, whether they should be sent for revision, or based on the reviews, if both peer reviewers or 3 peer reviewers say reject, they will reject it. If there's any discrepancy in the reviews, our policy is it has to come to a meeting. And we have a call every Monday afternoon where we discuss any discrepant reviews. And that's discrepant reviews within the peer reviewers, or if the peer reviewers are consistent and the associate editor disagrees, we discuss it among the entire associate editor staff and come up with a collective decision for that particular paper. So that's generally the process. In that context, the editor's power to reject and accept is significantly diminished. Now, I don't know how other journals, outside of the ones that I've been involved with, work, but I can tell you that depending on the editor-in-chief's personality, if they're a very, very prominent, powerful person, absolutely, they will have an influence on what gets in. If there's someone who's a little bit more collaborative, it tends to be a little bit more of a group decision. And my philosophy has always been that if there are, people who have had any kind of an issue with our peer review, or they disagree, or they want to file an appeal, I generally try to communicate with them directly, either through email or a phone call, to understand why they disagree. Now, sometimes they say, you just didn't get it, it's a great paper. Well, okay, then we're just gonna have to agree to disagree. But if there's something that we missed, look, we've granted appeals on a few papers and have and in fact, one of them we actually ended up publishing, we were originally gonna reject.
Interesting. It gets to this point of, do editors, well, for instance, in your case, people may not know, you're a big radial first proponent. The hashtag radial first comes from you, right, Sunil?
Yeah.
So you know how to do a cardiac catheterization, whether from the radial or femoral. Doing it from the radial artery, you certainly popularized that, and that's one of the big, I'd say, wins in SOMI in terms of popularizing this, an access that is safer for patients and whatnot. So you clearly have a bias based on your experience and based on the evidence that currently exists. But I guess you would look pretty hard, or how would you look at a paper that was submitted that suggested that femoral first was better for whatever reason, radiation dose or what have you?
So thank you for asking that question, because I think it's really important. I mean, you're absolutely right. We all have our biases that are based on our own clinical experience, our professional experiences. And so I think that I'm hoping that I'm still at the point where I'm trying to be cognizant of those biases. And generally most papers that come in that have anything to do with an area that I have an interest in, a direct interest in, I generally have not handled those myself. So I still see them and I send them out for review. But it's usually handled by an associate editor, not by me. Now, I handle some papers on my own, but I try my best to sort of say, okay, I clearly work in this field. I have an opinion that is counter to what these authors are saying, but based on the methodology, even if I think that they're wrong, but the methodology seems relatively robust, we want to get external peer reviewers for that. Because you're right, I don't want to be seen as someone who's anti X, Y, or Z.
But so that seems to be the tack in medicine, that when you have biases, you get them to folks that don't have biases. But could that be part of the problem? Meaning, who better to kind of really look into the kind of the guts of a paper on radial versus femoral than a guy like you.
Yeah,
It's that, you have that content, you have that massive content matter expertise. Now, if we gave it to say some very smart person who doesn't know the fields, I'm sure Richard Horton, editor of Lancet, is a super smart guy who's ascended the ladder, for a reason. His ability, say, I don't know if he does peer review or not, but his ability to say, take apart a paper that's looking at femoral versus radial first is a heck of a lot different. Like, I want, for me as the guy out in the field who's the kind of the end user, I would much rather know what Sunil Rao thinks of this paper that says radial first doesn't work out well than have Richard Horton look at it.
So I think, again, a terrific perspective on that. And I think that if I could maybe broaden what you're saying, I think this applies to guidelines too, right? I mean, one of the challenges we've had with guidelines is that they have required absolutely no financial conflicts of interest. And oftentimes that results in, a makeup of an author group that may not necessarily be an expert in what they're supposed to be writing a guideline on. And so, yeah, we absolutely suffer from the same thing. My hope, though, is that process of dissecting and critiquing a paper occurs in the post-publication, because at the end of the day, the decision to publish should be based, in my view, largely, not entirely, but largely on whether the scientific methodology is robust and replicable, rather than what the results are. Now, I'll give you a prime example. So the Safari trial, for example, which is a trial of radial versus femoral and STEMIs, which came to a different conclusion than what the other trials did. It indicated there was no difference, whereas the other trials indicated that radial approach was better. Not to get too far in the weeds. That's a very well done randomized trial. It should be published. It was published in JAMA Cardiology. After it was published, we were all able to say, well, here are the reasons why I think the trial showed what it did. It was underpowered, it was stopped early, low risk patients, et cetera. But incorporating that kind of thing into the pre-publication process, I think, deprives the community of seeing an alternative point of view, which I think is a valuable thing, provided, of course, that the science is robust.
Right. So if this type of thing, the Surgisphere getting through, Lancet and New England Journal, and I imagine, just like the rest of the world, the riches in terms of resources that journals have aren't evenly distributed. So the New England Journal, I'm sure, has resources at their disposal that are multiple times other journals. If this type of review process allows things like Surgisphere to get through, what does that tell us about the rest of the rest of science, if you will?
Yeah, absolutely. I think it's a warning shot. I really do. Now, let's also be clear that all journals that have a print version, and even some that are online, have advertisements as part of their revenue, and they are dependent on the number of people who are looking at them and the eyes that go to that website. No one is immune from that. And the prime example that I like to quote for the New England Journal, and certainly not trying to disparage this at all, but you may remember the description of Takotsubo cardiomyopathy was published, the title of it was The Broken Heart Syndrome, and it was published in the February 14th issue of the New England Journal. So those guys and gals know exactly what they're doing when they publish that, right? So I do think it's a warning shot, though. I think that things like this, hopefully, make all of us a little more introspective about the kinds of papers that we're fielding, and allow us to at least entertain the possibility of really questioning where the data are coming from. Because I think, for all of us who are editors or associate editors or have an affiliation with a journal, this is one of the many things that keeps us up at night, is that we just don't want to put something out there that is that's just fake information that's going to affect patients.
Are there things oh, sorry, go ahead, Michel.
Yeah, Sunil. So what's interesting here is that it's not, at least what we alluded to this a little bit, but I'd like your thoughts maybe a little bit more precisely. It's not simply, in the case of the Surgisphere papers, it's not simply that it's, an egregious scientific error, but, well, at least there was, in addition to that, there was a kind of a political dimension.
Yes.
And to what extent, I mean, do you think that that's really what sort of drove the error as opposed to scientific carelessness? I mean, I think most people are going to conclude that there may have been some political motivations
Sure.
to that.
Yeah, I mean, my guess is there probably was some kind of a political dimension to that, and we see that in fields that are intensely being watched by the public. And there are plenty of those. I mean, this happened certainly with HIV when it became a big public issue. So I'm sure there was there probably was some influence of that. At the end of the day, if someone were to tell me that one of the papers that we published is being talked about all the time, my reaction as an editor would be, hey, that's great. We put something out there that people are talking about. But the dark side of that is that you want to make sure that people are talking about it for the right reasons. And if you let that drive the decision to publish, I think that it becomes a very, very slippery slope. And certainly, I think your perspective is valid that perhaps that may have influenced some of the publication of this, because as we said earlier, there are lots of people around that deal with big data, and if they had never heard of this thing, it should have raised a red flag.
Do you think, if you look back at the last 20 years or so, do you think there's more of that? I mean, that's more a greater danger nowadays than it was back then, or do you think it's just, there are periods of times or in history where politics has inserted itself in the medical research arena and it's inevitable? What's your perspective on this?
Well, I think my perspective is that it probably is a worse problem now for multiple reasons. One is that information is very easy to get now. Lots of people are getting lots of information. It's no longer being filtered through Walter Cronkite or whoever happens to be telling you the news. So there are multiple perspectives out there. So that's one reason. The second is that there are multiple outlets. So the number of journals just seems to proliferate, and they're all competing for the same, the papers that are out there. So that's one issue. And then the final thing is that because of the amount of information that's out there, everyone is sort of involved in politics now, right? I mean, to some degree or another. I mean, it was a very interesting article that I read in the lay press about how in the 1950s, it was very, very common for husbands and wives to have different political affiliations. For us to think about that now would just be almost impossible, right? I mean, and part of that may be the fact that, politics is show business for ugly people, and maybe scientific publishing is politics for even uglier people. I don't know. But I think you're right. I think it is getting more and more political, and we have to fight against that, or at the very least, entertain perspectives that may be different from our own biases.
That's a very good remark, I think. And so to put you on the spot maybe a little bit more, do you think journal editors have a role to play to try to stem that tide of politicization?
I personally do. I think that, we've become a little bit too focused on financial conflicts of interest in science. And I think there are multiple conflicts of interest. And that's why I love the description on Anisha's Twitter handle, right? Conflicts too numerous to count or something like that. I think that's true. We all have professional conflicts. We have political conflicts and intellectual conflicts. So, I think as someone who's an agent of the publishing world in science, I think I have a responsibility to try and make sure that things don't get politicized.
Right. Now, we had as a guest on our show maybe a few months ago, I think it was in December, Dr. Stanley Goldfarb from UPenn. And I don't know if you're familiar with him. He wrote a very provocative and controversial editorial in the Wall Street Journal, precisely sort of decrying the encroachment of social or socio-political concerns in medical education. And I don't think there's a right or wrong answer, but nevertheless, you can see that in a lot of research papers, there's a lot of attention to questions of things like the social determinants of health and things of that nature that invariably have a certain political slant to them, right? And is that a good thing or a bad? I mean, I don't think it's a very good thing, but at the same time, there's a reality that this is how much of academia views things.
Yeah.
And so, like it or not, I mean, that's how the scientific community likes it. What are your thoughts on this?
I think that that there is an entire world of social sciences that we as cardiologists don't really understand and don't use their research techniques. And so to the extent that the social determinants of health world of research is scientifically robust, I think it's a valuable thing to put into the peer-reviewed literature. What I don't like, and what I think is probably a bad thing, is when people use social determinants of health as a way to make their paper sexy. And it's sexy to publish about that kind of stuff. But if you don't have the right analytic tools, you may get the wrong answer. And the wrong answer is not what we should be publishing. So, I'm not someone who thinks that, any kind of scientific research should be censored in any way. I just think that you have to have the right tools to analyze those things. My mentor was Bob Harrington, who always said, there shouldn't be a dichotomy between observational research and prospective randomized trials. It all depends on the question that you're asking. So if you're asking a question about social determinants of health, you should use the appropriate techniques to analyze your question. And if you're using the wrong techniques, if you're using standard techniques that we like to use for other kinds of questions, you may get the wrong answer. And that answer may be very sexy from a political point of view, and it may get it published in the highest journals. But if it's the wrong answer, then I think you've set the field back.
Can you give us? Are you able to elaborate more? What do you mean by the methods? Do you have an example of something? Or are you talking?
I'm certainly not an expert in this, but the social sciences often use qualitative research methodology that we're just not very good at. I mean, cardiologists, we think of ourselves as very quantitative, right? The patient is dead or alive at 30 days, or the patient has had an MI or has not had an MI at 30 days. But the social sciences tend to be, use qualitative methods that involve patient-reported outcomes and interviews, and I'm just not an expert in those things. So when we get papers like that, oftentimes I just say this is not the right journal for this paper. This needs to be sent to a more qualitative methodology journal where people understand those techniques, and I just don't understand them. So yeah, I mean that's the kind of thing that I'm talking about. I mean, if you're talking about social determinants of health, it may not necessarily just be about whether the patient is alive or dead. It may be about other more qualitative things that have to be analyzed in a different way.
Right. Although, Sunil, if I can give an example, it wasn't a clinical trial, but it was a sort of a natural experiment paper that got a lot of press. That was published last year. We made some comments about it. You may be aware of it. I think it's Anupam Jana's group, who published on mortality outcomes from medical hospitalizations, depending on whether the attending physician was male or female. And,
I do remember that.
Right. So,
yeah.
So if your attending physician was a woman, you had a better chance. Your mortality was greater if it was a man. Now, of course, there were some problems with this. Anish keeps harping on the fact that you get multiple. It's not just you get one attending; you get multiple.
Right.
It's very hard to sort that sort of thing. But let's imagine you had somebody submitted to your journal outcomes, interventional outcomes, and that somehow men had better mortality after a cardiac intervention than women, and you thought that the method was very robust. How would you feel? How would you deal with a paper like this?
Yeah, it's a great question. As you were talking about that, the first thing that popped into my head was unmeasured confounders, and we deal with this all the time in observational research, and so this is why it's very difficult sometimes to get observational research funded. And when I read that paper, I think that the methodology was robust based on the data that they had, but the challenge for anything like that is really unmeasured confounders. So it would be unlikely that we would publish any paper that would look at something like that, because again, that's a paper where, or that's a study that really should be done prospectively, collecting all kinds of stuff that is not necessarily available in the data set. I mean, maybe Surgisphere has it, but no, I'm kidding. But any kind of existing data set certainly doesn't have it.
It's remarkable.
Yeah.
Sorry. Are you in the minority, Sunil? And do you think in the community of editors in terms of and thinking like this? I mean, it seems like you have you're a stickler, which is a good thing. You're a stickler for the science behind it, not so much. You're saying that the sexy answer is not necessarily, it's great that you have a sexy answer, but really, if you don't have a robust study which is able to kind of, it doesn't have like holes you can drive a truck through, then we're not very interested in publishing that. Are you able to do that because you're in a niche journal, or is this something that's, or are you just in the minority of editors that think like this?
Yeah, I don't know the answer to that. I think that there are certainly my colleagues on the journal who have kept me honest in that regard, and we certainly have pretty intense discussions sometimes about some of these observational data. It always comes down to, is this something that people are going to read? Are they going to reference it? And if the answer to both of those things is yes, then we say, well, listen, is this the right answer? And when I talk about methodology, I don't mean just the statistics. I also mean the data source, right? If you're looking at, men versus women outcomes, attending as a man or a woman, and you're looking at Medicare data, well, gee, I mean, that's just not, you're not going to be able to adjust enough. Having said that, that paper will get published somewhere. I guarantee it. It will get published somewhere. Hopefully it will be in a little lower tier journal that doesn't have much of a readership. So I think that if you look at the vast sphere of scientific publishing, yeah, we probably are in the minority because, again, those papers get published. You and I see them all the time. And I think now with social media, those authors oftentimes will tweet them out, and get those things will get retweeted. And but I'm lucky because I'm in a subspecialty journal of a larger journal that also has a very robust scientific process.
Although, do you think it would get published if it had a less politically correct outcome?
I do. I mean, a lot of papers that we see that we look at and say, geez, this is just a terrible paper. You end up seeing a couple of months later in a very, very small impact journal. All scientific papers that are written that have, a reasonable data set eventually get published. It's just the sad fact of scientific publishing. There's a journal that's out there, barring the ones that want you to pay to get it published, that will take a lot of these papers. So it is unfortunate, but I think it does happen.
So why don't we'll wrap up. Why don't you tell us, based on this kind of nightmare-inducing for editors experience in terms of this data and possible fabrication, what are the concrete things that you think that can take place moving forward to kind of help the process? Have you done anything at Circ Interventions, or has the larger circulation group suggested anything different based on what's happened in the last couple of weeks?
Certainly not just based on what's happened in the last couple of weeks, but just in general, what we've discussed, our own journal, and certainly I've discussed it with editors of other journals, is particularly for randomized trials or even some of these other data sets, should we require an analytic data set to be submitted along with that paper? Now, we have asked for protocols to be submitted. So you have to submit your protocol, and we have to be able to see it. The problem, I think, is that observational research has become a little less rigorous. So if you're going to do a prospective randomized trial, the journals want to see your protocol. They want to see all the changes on clinicaltrials.gov. They want to see an analytic data set. For observational research, we just tend to trust the authors and say, yeah, you probably did a pretty good job. But my personal view is that I think, it's episodes like this that tell us that the overall model is not as solid as we think it is. And so what I would like to see is for the authors to, send us your analytic plan that has a date on it, so that we know you didn't just go data mining and come up with some result that you said, hey, this is pretty sexy, let's get it out there. But did you have a hypothesis, or did you have some kind of a plan? And then, if it's something that we just think is just so novel, send us your analytic data sets so that we can look at it. Now, it's easy for me to say that, but none of this exists in a vacuum, right? Oftentimes, these large data sets, you don't own them, you rent them. So CMS data, you're renting it from the government. So they have to approve you sending that to someone else when they don't have a data use agreement. So there's a tremendous amount of bureaucracy around this stuff that we have to try and tear down so that the science can, in fact, be something that people trust. I almost sound like a libertarian.
Well, on that note, do you feel threatened by the all of a sudden the the COVID accelerated path of preprint and peer review by Twitter?
Yeah, so that's a great question. Originally I was very threatened by it. And then now I realize as an editor that it's actually a really important thing. What I think the danger is when you have the lay press not understand the difference between a preprint and a published paper. And we have to do a better job, the scientific publishing community and the science community has to do a better job of explaining that difference. So, we've got a couple of analyses that our research group is working on, and we are going to put them on preprint servers because, I do think it's the right thing to do.
Fascinating.
Yeah.
Sunil, thank you so much for the time. Really wonderful conversation.
Absolutely, and thank you again for the invitation.
All right, Sunil can be followed on Twitter. Sunil, your handle is
@SVRaoMD.
Excellent. All right, thanks so much again.
Thank you.